Hi, this is Dr. Carl Goldkamp. A few things I have to say. One is, we personally are involved both as a lifestyle, the ketogenic diet, but also through my 16 years of clinical practice of what is effective. What do people need to take sometimes, all the time, to support their ketogenic diet? You'll get bits and pieces of this ongoing week after week. It's important to be comprehensive. In one way it's simple, and one way it's a little bit complicated.
Welcome back, everybody, for the next episode of the Keto Naturopath. Today, we have a wonderful person to interview, and I'll say wonderful. First, I'll give you my personal, and then I'll give you a formal of what she does. Wonderful because I met her, got to watch a number of her presentations at the first and second Metabolic Therapy Conference, and you just don't know what to expect. So Beth Zupec-Kania is our person we're going to interview, and I would have said up until a couple months ago that she was focused primarily with epilepsy and associated with the Charlie Foundation. And that's a great story by itself, but she's gone way beyond that. And the reason I wanted to talk to her, because it became apparent that she is one of maybe two or three people, I would say one of two people, that has the greatest experience in implementing on a one-to-one basis the ketogenic diet. So from that, before I let her speak, I'm going to read what her background is, and so you'll catch your breath at the end. So Beth is a registered dietitian and nutritionist who has promoted safe and effective ketogenic therapy since 1991, which is a couple years prior to the inception of the Charlie Foundation. She's managed ketogenic diets in individuals with autism, epilepsy, of course, multiple sclerosis, mitochondrial and metabolic disorders, migraine, rare genetic disorders, several cancers, and Parkinson's disease. Authored the Modified Ketogenic Diet Therapy, 1-to-1 and 2-to-1 prescriptions with the Charlie Foundation. Numerous education guides, co-organized 3 global ketogenic symposium, and is the designer of the Keto Diet Calculator, which I've used, which is very thorough. It's meant for practitioner and patient, if you will. A web-based program for calculating ketogenic diets. Beth has provided training for over 250 medical centers worldwide, owns Ketogenic Therapies, LLC, and is a consultant to the Charlie Foundation, a nonprofit that educates and advocates the ketogenic therapies. That's a mouthful, but that shows how applied this is, the ketogenic diet therapy, even though the heart is my guess with you, Beth, it has started with epilepsy. Is that correct?
That's right.
So take me a little forward. Let's do a little history. How did you get started? Because this is quite a specialty. Most registered dietitians don't have this kind of specialty that you have.
You know, I just happened to be in the right place at the right time. And the head of neurology came into my office at Children's Hospital here in Wisconsin and said he needed somebody to do the ketogenic diet for epilepsy, and did I know anybody that would be willing to do this? And I said, I don't know anybody that would, but I'll take it up to our manager. And long story short, I was intrigued by this notion of a diet therapy being powerful in controlling seizures and in curing epilepsy in some cases. So I talked myself into it, and so that was a long time ago. But I was, the first kid that I worked with that started on the diet, and who was it like a different child the next day, just hooked me. I knew from that point on that this is what I was going to do the rest of my career, because he turned around from being sort of this limp, little boy that had no cares about anything into being, active and curious and doing all the little things that little boys do. And he wasn't even seizure free. He just had better seizure control. And over the course of several months of working with him, he became seizure free. And that just impacted me so much. I just thought, how can a diet do this? And then how could I ever leave this? So it sold me, and I have been doing it ever since. But I left the hospital after several years, after about 20 years, because I kept getting invitations to write papers and collaborate with people and get involved in speaking. And I just knew I would have the ability to do that if I were on my own and not stuck in a sort of a 9 to 5 hour a day job at the hospital. So I did. I branched out, and I've worked with. That's allowed me to work with people with many disorders, and people with epilepsy, have cancer and they have diabetes and other disorders, and that's sort of where this has been evolving from. That it works for many more conditions than it was initially designed for.
That's amazing. I've read about the history. You go from epilepsy has been the ground zero for the ketogenic diet, and it seems like all roads lead from epilepsy, whether it's into diabetes or to cancer now. But we all know you can go back to fasting backward to Hippocrates. What's that? 500 BC. So with the fasting and coming forward up into the late 1800s, and so. Before insulin, my understanding is you had this thing called the Allen's diet, even though this is before type 1 diabetes, but it looks like they took a page from epilepsy and they had, it's a calorie reduced ketogenic diet, which is just a step away from Thomas Siegfried's, cancer diet. He has a few other additives in there, but it's like, this is all, epilepsy is I hate to say the juiciest part because it's the saddest part as well, but it's the place with the greatest change. And it's amazing. Does that history sort of like, when you see that, do you take on that history and go, this is like, it's us, everybody comes to talk to us because we are the center of it. I mean, that's how I see it.
Yeah, it is so fascinating to know that history, and that Frederick Allen figured this out a long time ago. He was way ahead of his time, and he was just too radical, I think. But he also, I think, went a little bit beyond. Unfortunately, some of his patients died of starvation because he did starve them. And I'm referring to people with diabetes who he had fasted and noted that their pancreas healed and recovered, and they were able to make insulin again. But I think he took that a little bit too far, and some of those people died, and that's where he lost his momentum. But he's definitely somebody that has helped to bring this to light. And here we are 100 years later, and this diet is still sadly underused for epilepsy, which it was designed for initially, very underutilized despite the research, despite a randomized controlled trial in children and several retrospective and prospective studies in children and adults. I mean, there's a lot of research showing how effective this therapy is, and yet doctors still are not prescribing it. And that's really, a sad statement of our health system.
Absolutely. I know it's probably more politically correct to say that, and I'm a naturopath, and I didn't know this. And in fact, I was in medical school at the time the Charlie Foundation First Do No Harm came out. So you would have thought that would have been like, everybody come down to the auditorium and let's watch this together. I learned about this only in the last 10 years, so I don't know how we missed that. But so it's more politically correct, say everybody's uneducated, nobody has an axe to grind. But I think it's a little more than that. Do you just sort of say the world is what it is? I don't know if it's lack of education or purposeful avoidance because of other incentives. I mean, do you have any sense about that? Or
there's no money in this diet, right? Who gets paid when you put somebody on a ketogenic diet? Even a nutritionist in the hospital probably does not get paid for that. The hospital probably doesn't get reimbursed for that. So that's one of the huge issues that we face. And I've been trying to change that by working with my professional association to get practice guidelines published, which we just did a few months ago. And so that there is now a consensus in my profession of, how this diet should be applied and when and all those good things. And then there's a consensus report of mostly physicians, but some of us nutritionists. I'm the second author on it that was just published actually a couple weeks ago with global input on use of this therapy for epilepsy in children. And there will be a new one out soon for adults too. But those are big change agents. That's the foundation that makes the healthcare professionals comfortable when they know that there's publications to back them up. So that's very important steps to have. but we still need more oomph to get physicians and others on board with making this available at all medical centers rather than just academic medical centers, which is, you mentioned that I train medical centers. Most of where the centers I go to are academic medical centers that are on top of the cutting edge therapies. Your little community hospitals and hospitals in smaller cities, they just don't have the ability to do this yet. I will say yet.
Yeah, this reminds me of the origins of the whole Charlie Foundation story and the oomph that Charlie Abrams sort of gave the whole thing. Do you want to touch on that briefly? Because it is about, it's not what I've learned in my naivete of being a naturopathic doctor. It's not about having the right answer or being truthful. It's about that, of course, but it's about having the microphone or having the platform or the ability to get the word out and, enter Charlie Abrams and Charlie.
Yeah, so you're exactly right that Charlie was meant to be a change agent. I don't think he even comprehends that. Charlie had seizures starting at about age 1, and he was tried on the typical anti-seizure medications. Actually, they tried him on 7 different medications in different combinations, and his seizures didn't get better. They actually got worse, and then he had an epilepsy surgery. And his dad, Jim, went to the medical library at UCLA, which is close to where they live, and read through a lot of medical textbooks thinking there's got to be something else. And he came across a book that had a chapter on the ketogenic diet. And he took this to Charlie's doctor and said, "What about this therapy?" And the doctor said, "Well, we don't do that here." And Jim said, "Well, where do they do it?" And he said, "Well, I think they do it at Johns Hopkins." And Jim said, "Well, we're going there." And, soon he was off with his family to Johns Hopkins, got him admitted. And in a few days of starting the diet, his seizures stopped completely. And so once they got back and were sort of in disbelief that, how drastic this change was. And he was also taken off of all of his anti-seizure medications, which is not typical for the process of going on the ketogenic diet. But he had a very aggressive doctor, Dr. John Freeman, who is no longer with us, but he kept the diet alive for many years, along with his dietitian, before no one else was really doing it in the country at the time. But the family, Charlie's family, realized that that they were lucky. And had Jim not pursued this, what would they have been dealing with? Charlie would have been in a wheelchair, probably with a feeding tube, due to his diagnosis of Lennox-Gastaut, which is a really bad seizure disorder that it's like the worst seizure disorder you can have. So they started the foundation to advocate this therapy for others. And then in 2012, we changed the name from Ketogenic Diet Therapies to Charlie Foundation for Ketogenic Diet Therapies. So we wanted to open the doors to everyone who could benefit from it. And certainly by this time, studies were coming out about its use for diabetes and for cancer and psychiatric disorders. So we did not want to limit the diet because they're similar for all conditions. You really have this basic high fat, low carb, moderate protein diet that you adjust to, and they're all individualized. A ketogenic diet should be individualized to make sure the nutrition part of it is sufficient. So we open the doors to all comers who could benefit from it. And that's the way the Charlie Foundation has been moving since then. And I want to share with you, I can email this to you, Carl. I don't know if you can share something visual, but we just had a cartoon designed showing, and it's called Keto versus Goliath. And it's a picture of Charlie flinging a pound of butter at this giant with a shield. And the shield has, insurance companies, American Heart Association, medical systems written on it. So it just kind of depicts what we're up against in
Yes.
getting the word out.
Please, please, please send that to me. And
Okay.
we have a Facebook group. I wanted to stay on that particular note. So when Jim Abrams got Charlie to start the diet, back then, my understanding is, and maybe it's still the case, is that they started with a couple days fast and then they started the diet. Is that correct?
That's true. That's true. That is what had been traditionally done. And the fasting is just a rapid fire way of getting into ketosis.
Right.
I'll tell you, having worked in a pediatric hospital for 20 years and working with this diet, I thought the fasting was a little harsh and unnecessary. So I went to our medical supervisor and got permission to strip away the fasting, so that you usually fasted for 2 days or until ketones were large. And I realized that these little kids were going into ketosis so quickly, and then they wouldn't eat because they were kind of lethargic, and they'd be in the hospital for an entire week, and it was horrible for the family. But I thought, what if we just start feeding them the diet and not fast them? And we did a review, and we found that they go into ketosis either way, and it doesn't change the efficacy of the diet. So since then, other centers have reported the same, that non-fasting does not change how well the diet works. And you get kids in and out of the hospital quicker. They're less likely to catch bugs in the hospital. So it's just a slicker way to get them on the diet gradually. And then now that I don't work in a hospital and I work from home with people all over the world, I even toned that down a little bit. When I start children or adults, I do it over a period of a few weeks to get them acclimated. We just change one meal over a week to keto, and they start going into ketosis gradually, and they don't seem to get that keto flu. That's very common with a rapid startup. So it's just a gentler method of getting onto the diet.
Does that have any, per your experience, does that have any correlation with sustaining the diet for them? In other words, they more gently get into it. Do they stay on it for years and it becomes part of their lifestyle? Or, they're just into it and they're they get annoyed with it and they're going to quit, down the road? Is there any sort of...
I'm glad you brought that up, because people think that you have to do this diet forever for epilepsy. We actually use it short term in most cases. In about 97% of cases for children, we just use it short term. So for the example of Charlie Abrams, he was on the diet for 5 years, and that's a little longer than normal. But what happened was they tried taking him off at 3 years, which is typical, and his seizures came back. So they put him back on and waited a year and took him off, and his seizures came back. So the third time was the charm. The third time they took him off, his seizures did not come back. And now he's 25 years old, I think. He hasn't had a seizure, since way back when he was 5 years old, when he was coming off the diet. So, but most of the kids I've worked with were on for 2, maybe 3 years. Some have been on for shorter and are completely seizure free. There's a few rare genetic disorders where we keep kids on long term because they have an impairment in the ability to use glucose in the brain. So those are very rare genetic disorders, but those kids stay on. And we use a little bit more liberal diet, so it's easier for them, and they don't have to weigh foods all the time. And a lot of them will drink MCT oil because it's very ketotic. It's very ketone producing, and it allows them to eat more carbohydrates. So we have some tricks to keep them going so that they stay in ketosis. And as they get older, by then they're into the routine of it, and they realize the difference if they cheat or not cheat. And most of them do quite well.
Great. So they have a basic understanding. So they might say they're off the diet, but it doesn't mean they're going to go to birthday cake and drink beers and have, Captain Crunch for breakfast anymore.
Right. That transition, the teenage transition time, has been pretty tough for some of the kids that I've worked with. I know one man I'm thinking of in particular who was very compliant with the diet. He actually had a feeding tube because his epilepsy was so bad and he couldn't function. And then he was on the ketogenic diet and he was able to eat again, and they removed the feeding tube and he got off of medications. He was doing so well. And then he wanted to go live with his friends, and he started drinking beer and eating pizza. And he was having some major seizures. So it took him a while to really get on track. And he definitely is one of those kids that has to be on it long term. But some kids just know intuitively what they can and can't have, and it's amazing how these little kids even know. I have a 4-year-old who his sibling offered him a cookie without his parents knowing, and he turned it down. He just knew he couldn't have it. So that's pretty typical of a lot of the kids that I've managed.
Interesting. So when we talk of the diet, as I saw you present in one of your presentations, can't remember if it was online or not, for those way outside of the specific epilepsy field, we think there's this one diet, but there's not. There's in essence 4, and then it's variations, and then goes on from there. So, when we talk about the classic ketogenic diet from Peterman or Wilder, whoever we want to cite, the medium chain MCT diet, modified Atkins, low glycemic, do you have a preference, or you just sort of see these as 4 tools in your bag, and if one didn't work, we'll go to the next, and the other didn't work, we'll go to the next, and in there someplace we'll find the right combination?
Right. So I'm glad you pointed that out. There are variations in these diets, and the classic ketogenic diet and the MCT oil diet. Those are the old original ketogenic therapies that textbook and very controlled and very effective. And then we have what we call the hybrid diets, the newer diets, the modifications in those. And those were designed to make it easier so that people could, stay on it longer, and that adults would be more compliant. So the idea really is to find the diet that the patient finds will work best for them. And we at the Charlie Foundation have some good education guidelines for that, so they can kind of compare and contrast the different diets and understand what the difference is. For example, the classic ketogenic diet, let's say a 3-to-1 ratio, you have to weigh your foods on a scale. And someone might say, oh my gosh, that sounds so labor intensive. Well, it is, but you know what? It works. Well, what if, that's a little bit too much work for my family right now, because mom and I are both working full time, and the kid is at babysitters, and we just don't think that's going to work. Is there something easier that we could start with? And the operational word here is start. We may start with something more liberal and then see how that goes, see what degree of ketosis is, and maybe the degree of seizure control. And if things are great, we just go along with that plan. But oftentimes people find that, we want to see if we can get a little bit better seizure control, because we're down like 50% of the previous seizures, but something is working here and we want to pursue this. So maybe we will start weighing foods. So that's very typical of working with a family, is get them at a point that they're comfortable with one of the diets and then adjust as you go along. Another example is I tend to choose classic keto for all children under age 5. I just think it takes all the guesswork out of the diet for the family to be able to have meal plans with weights of each of the foods. So they just weigh out the foods and they feed it. They don't have to make any decisions beyond that. And so then once we get going on that and see what kind of results we get from there, then we bring in MCT oil if we need to make ketones stronger. And so that's not changing the diet very much. That's just incorporating a different fat, reducing maybe some of their butter or their olive oil and bringing in MCT oil 3 times a day. And that can beef up ketosis. And maybe that's the magic change that gets rid of those other seizures that they continue to have. So there's a lot of little adjustments. And I just, it's at the printer right now. I just finished with a collaboration of 2 other nutritionists and a physician on a professional guide for managing ketogenic therapies, all these little trips and tips about oils and adjusting the diet for age. And if a child can't be eating by mouth for a while and needs to be fed a liquid diet, or if they're in the hospital and they're really sick and they need to be fed through their vein, how do you adjust for that? So all these tips and tricks in 122 pages in a little pocket guide currently at the printer, but it took us about 2 years to get that into print. And I can't wait for me to be able to distribute it, because I feel like it's going to save so much time and help people understand all of the ins and outs of using this therapy, because there's a lot of that.
Absolutely. 122 pages doesn't sound like a little guide. It sounds like a comprehensive guide, but splitting hairs, I'm glad that it is 122 pages. So on the MCT oil diet, do you ever go like kind of one step further and sort of split the C10 from the C8 and say, hey, let's do C8 more because it's a little more ketogenic, and, make mayo or whatever the different sauces are, but, separating that out, does that have any differentiation that you've stumbled upon or implemented?
Yeah, actually that does. And I have a page sort of addressing that very point. And for your listeners, I don't know if they're educated on the different chain links of MCT oils, but MCT oil, most of it comes from coconut oil in this country, and there are different carbon chain links, and so they're identified by numbers. So there's C8, C10, C12. Is there 14? I think there's then 14 and 16, even 16, right?
Yep.
And so some of the cheaper oils have a combination of all of those. And then some of the more refined oils, like the C8 that you're talking about, that I know you also produce, it may just be that one carbon 8 chain length, and there is some research behind that. It is more ketogenic, and it may be a more ideal oil for epilepsy. So I found this out before I met you, Carl. I kind of stumbled into a situation which made me realize that there are differences in how those chains can affect a person. So I had a child with autism that was on a kind of a low-cost MCT oil, and the family ran out of it, and they went and got a different oil, a different brand. And his behavior, he had some, behavior outbursts that were not typical of him. And they said, the only thing that we've changed is this oil. So then they went and bought the old oil, put him back on it, and the behavior outbursts went away. And then They just thought, well, let's just try a couple doses of this, because we bought a whole bottle of this and I hate to waste it, and it's not cheap. And the same thing happened. He had this behavior outburst. So they called me and I said, you know what, I do think it's probably the different chain links. Let me check into it. So I contacted the companies and I found out, sure enough, one had, a very little C8 and more C10, C12, C16. And then the other one was not pure C8, but it had quite a bit more C8 in it. So then I thought, oh my gosh, I never realized that these could have an impact on brain health. So I contacted about a dozen companies to find out their carbon content. And that's one of the pages in this. It's a chart just listing the carbon content percentages of each of these products.
Dr. Stephen Kania, he's a wonderful guy, and I love listening to him. And he's been interviewed, and I've talked to him and go back and forth all about C8 in particular. C10 has its value as well, but he's big into C8, and he is kind of the mover and shaker on the research for the C8, and that's a lot where I get a lot of my information from, and kibitzing back and forth with whatever little thing that I come up with, and he verifies it or says it's irrelevant or whatever. But the other thing I wanted to add is that in the U.S., you're right about the MCT oil, which is, we call it the mixed products out there, are from coconut oil, but the C8s, nearly 100%, even though they don't want to claim it, are actually all palm oil derived. And it doesn't matter to the consumer. To me, it matters because palm oil has become such a successful agricultural crop in Southeast Asia, parts of Africa, and now South America, that it's certainly devastated part of the inherent rainforest jungle. And so you try to look for sustainably harvested. And it's such a touchy issue when you go to ask whatever company it is that made their C8 and say, oh, is this sustainably harvested? They have no verification of it. I mean, there are RSPO is the answer to that, but it's a little bit of a plug. But when you see both sides of it, it's a huge issue. And it's an interesting issue as well. And it doesn't mean that coconut's any better. It just means coconut's an unregulated industry, and it's having its impact. So, like everything else, it affects the environment. Merely FYI, but I do think it's remarkable to see some people think, oh, because it's an even number, the ketones are 4 and the C8's 8, so you got 2 ketones out of every maybe, but I don't know. But that's neat to hear. I wanted to drill down on some other aspects as well, because now we're going to go to food in terms of just you implementing these diets. So all these different fields now, it doesn't have to be just epilepsy. Are there certain foods, and I mean like dairy or not dairy, how do you feel about that? Where are you on the fiber side of things? Irrelevant or no, it's relevant. Are there certain things that you pull out and saying, a certain family of foods that I try to shy people away from? Certainly the refined carbohydrates, I got that, and the grains and the starches. But do you have strong opinions about something else in there?
So let's start with dairy, because that's a bit of a hot topic. Most of the people that I work with are able to tolerate dairy. They've never had a problem with dairy, except for some of the kids with autism, who I definitely support parents when they say we don't do dairy and we don't do gluten. The gluten is very easy. The classic ketogenic diets are intended to be gluten-free because gluten breaks down into carb very quickly. So that's not an issue. But so I've done a lot of dairy-free, particularly for the autism community, and I support that. But for others who seemingly don't have a sensitivity to it or any GI issues, I like to incorporate it. Dairy fats have, especially butter and ghee, have short chain fatty acids. So we were talking a lot about medium chain, and now here's another, great chain of fat that's unique mostly to dairy, and it has many benefits. It's food for our colonocytes. It helps to change K1 to K2, which is really important for heart health. I mean, it is just a unique fat. Not to mention that dairy is, like butter is so tasty, it makes foods taste tasty. Cream, and especially heavy whipping cream, can be delicious for making, sauces and gravies for keto, and whipped cream and berries. Who doesn't love eating whipped cream with berries, on keto? And I follow keto myself, so I've really gotten into the foodie part of this because, I'm a picky eater in terms of I rarely go to restaurants because I always think I can make food better than the restaurant. And, I don't know where their food comes from. And I certainly don't go to fast food restaurants at all. But I kind of pride myself into eating a pretty clean diet. But it is good to have some variety. And I was vegetarian for many years. I was lacto ovo pollo, which means I eat dairy, fish, and poultry. And I kind of got away from that when I got married because my husband was a big meat eater, and I didn't want to be making 2 different meals. So but he's cut way back on meat, and I've introduced a little bit of meat into my diet, mostly poultry and fish though. But at any rate, getting away from what you originally asked me, I think dairy can be a very good component and certainly offers good culinary elements to a keto diet. And, for the classic ketogenic diet, very rich in dairy. We use whipping cream instead of milk for children, and butter was the main source of fat. Now, when I came along, started working with this diet 25 years ago, I thought, wait a minute, where are we getting our essential fatty acids on this diet? They're missing. So I used olive oil to get omega-3s. And then there's vitamins in olive oil. There's CoQ10 and vitamin A, and avocado is high, and avocado oil are high in vitamin E. And avocado oil is the better oil to cook with. Olive oil is heat sensitive. So I think using both of them is like the best mix to use with a ketogenic diet. In terms of fiber, I'm not sure. Do you mean like adding a fiber supplement or including foods with fiber?
Well, both actually. Some people that outside of the epilepsy and the ketogenic diet for therapeutic purposes, sort of, they're saying, well, what they talk about, what are keto foods or not. And so as they come in, and we now know there's a lot of people under this umbrella of ketogenic diet. So there's way down there, the zero carb, which are primarily carnivores plus fat, and that's it. And then you have all others are vegetarian keto. That's a harder way to go, but they can do it, supposedly. A lot of work. And so within that is the fiber issue. Those who move away from greens towards a zero carb way of looking at it, they go, well, where's the fiber? It's also fiber in the meat as well, but it ends up being that issue. And then you see products like that are, net carbs, so which makes fiber the indirect issue. With or without fiber, do you have any sort of concern about? Not when I say concern, attention around that, or you go, well, who cares? They'll eat their veggies. It's just not, in your way of looking at it, it's just not that important of an issue to pay attention to.
Oh, I think it is an important issue. First of all, I think it's total carb, or are we counting the carbohydrate minus fiber, which we call net carb? So I think it's fair to ask that, because if you're only allowing yourself 20 grams of carb a day and you're counting the fiber as carb, that's really restrictive, especially if you're eating most of your carb from vegetables, which is what I encourage. If we subtract out the fiber and just count the absorbable carb, which is that net carb, then it seems like you get a lot more vegetables, right? You do, because you're not counting that fiber. So fiber is carbohydrate that we don't digest, don't absorb. It doesn't affect your glucose. So I agree that naturally occurring fiber in foods, we don't need to count them on keto. So in Keto Diet Calculator, which is the program that you mentioned earlier, I have a column that is net carb and a column that's fiber, so people can see how much fiber the food has, but they will only be counting the net fiber and their total carbohydrate. Now, I think what I get concerned about is when people are eating processed keto bars that have inulin or other fibers added to them. That's not, they may be naturally occurring, but because they've processed them into a bar, they might be absorbed differently. And I don't feel as comfortable about saying we don't count that, especially the like fructooligosaccharides. Some of those get absorbed. So what I do to circumvent that and not to have an argument with people about it is see how it affects you. Check your glucose before you eat that food and then after. And I just did that the other day. I had a glass of wine that supposedly had a fraction of a gram of carbohydrate in it. And I didn't really believe it because I tasted it. And man, I thought, well, this is really good. And it's a drier wine, but I don't believe it's nearly carbohydrate free like the company claims. So I checked my glucose before I drank it, and I checked it again 10 minutes after I drank it. My glucose was at 85 and it went up to 105. So I know that there definitely was more carbohydrate and it definitely affected me. Now, it may have affected somebody differently. I'm not criticizing the company that makes this, because these products are evaluated in a laboratory by machines. They're not people that evaluate these. It's not tried. It's sent through a person's body to see what comes out. It's evaluated by a machine. But in my body, that carbohydrate got completely absorbed and it shot up my glucose and knocked me out of ketosis for a little bit.
I love the fact that you still do your own testing, because those are the great stories. I have two questions. I'll stay with this one. The value of monitoring, whether we're talking about, I'm going to call them patients, by the way, you might call them clients. So all your patients that you work with, do you require that, hey, they have to have a ketometer and a glucometer, and this is going to be our ongoing vocabulary? We'll be talking about what does this do for your ketones and your glucose? I mean, do you require that? Or do you go, you can just have your urine strips? And I mean, where do you fall on that?
Yeah, so really good question. I tend to start people out with urine strips just to get them going mainly because of the expense factor, and urine strips are fairly cheap. And then once we get going and then they start acclimating to this and getting more concerned about things or getting curious, then I say, would you like, this might be a good time now to start checking glucose and ketones. Um, I had a little 4-year-old with epilepsy who I started on the diet, and I brought out the glucometer to show mom and dad how to check, to get a drop of blood and to put it in the strip. And the little boy ran away and hid. He was just mortified that his parents would be doing this to him. And they looked at me and they said, we can't do this. And I said, oh, don't worry about it. We'll just do urine. So for that child, we just did urine. And when he goes in to see his doctor, they draw blood work to get his, levels of different biomarkers, and they'll check his ketones at that time. So that worked for that family. But most of the adults that I work with, especially adults who have either cancer or other serious conditions, they tend to, eventually move over to doing glucose and ketone. And I really like the monitors that check both glucose and ketones, because the ketones are great. To get a ketone value is wonderful, but to get a glucose value, it tells you so much more information. It tells you, and the trend especially, usually not one reading, but seeing the trend over time can be feedback for what you're doing or what you're not doing so that you can adjust.
Absolutely.
And, yeah.
No, again, you're talking about the keto mojo. I think that's great. What a neat idea. And you need to make all the little factors that make the ketogenic diet difficult, less difficult. And that's one of the factors that get this, and they don't have to, have the different monitors and so on and so forth. I wanted to go back just a second for the dairy thing. I love the idea that you're focusing on the fats. What do you think about the casein and the whey, the cheeses and the casein and the whey? So the casein has a huge case of morphine, it's an opiate, and has a huge addictive quality to it. The fat parts, the butter and all the near butter products really don't. That's one thing. And then you can go down the road of, what problems that might cause. The whey, in my understanding, is insulinogenic. I mean, they both are. One's more quickly insulinogenic and the other is more slowly insulinogenic. As in bodybuilders, they love that aspect. They're right up there next to insulin, and they even will take insulin to bulk up more. So you have that, and the degree, I guess, that insulin is a factor to these various situations, if not specifically to some cases of epilepsy, it might be, a problematic thing to bring into the diet. What are your thoughts on that? That's just me casting.
So again, I think what I was trying to get at was you're talking about more like cheese and yogurt, and and I do discourage both of those. Because cheese has carb. It's quite a bit of carb. Cheese is made from milk, right? So it's quite a bit of carb. If people miss the taste of cheese and really want to incorporate once in a while, and a really good aged cheese like Parmesan, and aged Parmesan is quite low in carb, high in fat. But I have a woman who I just started on the diet, and she kept asking me for meals with cheese. And I said, what is it with you and cheese? She goes, I eat cheese all the time. And I'm thinking, oh my God, this is the problem. She eats cheese 2 or 3 times a day. So I do think we need to get away from the cheese there. And as far as yogurt goes, I would gear people to, there's a really good coconut yogurt, high-fat coconut yogurt that's out. If you're in Wisconsin, there's a company called Slowpokes that makes a fabulous kefir with coconut, and it's just delicious. But the other thing is you're not going to be eating like 12 or 16 ounces of yogurt at a time. You're going to be eating maybe 3 or 4 ounces so that the amount is small. But you're right. I do gear people away from cheese and yogurt mainly because of the carb content, but the casein is another good point, and the whey and the insulin stimulating properties, they are also concerning. So Those are not typical keto foods.
Right. Yeah, well, there are in some groups, but you're right. I mean, this is where I come at it. before I got into keto, just being a naturopathic physician, it was like, and taking people off of dairy was one of those things, especially with autism, as you referenced. But, now I have this sort of, per my experience, if I ran down the street and randomly, bumped into somebody and I said, do me a favor, stop all dairy for 2 months and let's talk in 2 months, their life would change. I said, even if they didn't even tell me there was a chief complaint. I mean, so there's going from, I've seen its effect by people going off this to trying to now dig into why is that. It's a bigger issue, whether you want to get it IGF-1 and all these other things, but it's a complex food that has issues.
Yeah. I am even aware of a story of a child. This must have been like a 3-year-old who was drinking 6-7 glasses of milk a day and not eating very much. And the child had seizures. And the dietitian, who's a colleague of mine, she looked at the nutrition intake and said, "Wow, that's a lot of milk. Why don't we just start with cutting back on the milk? Because you're not going to get that on the diet." In fact, she said, "I'm going to have you try some heavy cream instead of milk." That child's seizures stopped, and they never had to put him on the ketogenic diet.
Wow. I appreciate you saying that, because I'm kind of facetious in my reference, and I talk about dairy as a politically incorrect issue to talk about in the keto world, because people don't want to. It's like, don't do that. It's got a problem, and nobody. We already have enough don't do that's. To add that into it. We have like 3 more minutes to talk, so you can get out the door to get your some business done. But boy, I have so much to talk to you about, and so I'm just going to preference that for another call, I hope, in the future, because I would love to drill down. And I just wanted to say that I'm staring at an abstract from PubMed. And by the way, everybody, she has plenty of research papers on PubMed. Please put in her name next to that, in brackets, put author, and you'll see them all pop up. But this one in 2016, you've probably now forgotten about because it was so long ago, was towards a cancer-specific diet. And I go, isn't that interesting that Beth is working on this? And it's, we all think of Tom Siegfried and maybe Dom to an extent, and so on and so forth. But it's like, what are your thoughts in that direction, regardless of Tom's work? I mean, you have your own experience.
Yeah, well, I'll have to tell you, the whole reason I got into nutrition is because my father had cancer and died very young. He died when he was 52, and he started looking to nutrition after he got beat up by, the standard practice of chemo and radiation, and there was nothing left for him. So he turned to nutrition. That really piqued my interest. So that's been something that I have, never forgotten. And it's what drew me to treating food as medicine. And I've seen it happen, and I believe it. And, I think it was his lifestyle, and he was a smoker. He was a smoker of those short cigarettes from years ago. Nutrition wasn't really a focus when he was growing up. So at any rate, yep, I will just say that I'm completely in the realm of knowing how impactful your diet can have on flipping your genes toward developing cancer, because we all have cancer cells in our bodies, all of us, even as healthy people that are nutritionists, we all have these cancer cells in our body, and it just takes some kind of abuse for us to flip those genes, for those epigenetics to change. And the way you can prevent that is by treating food as medicine.
How Hippocratic, eh?
Yeah.
I'm going to let you get off in a second, but your segue into epigenetics is a big door to go through. And it makes me want to ask about, have you or any of the people you've worked with, which are now many, looked into any sort of the SNPs, the singular nuclear polymorphisms that I'm thinking about towards folate metabolism and methylation and so on and so forth, relative to any of the things you look into, whether it's epilepsy or, B12?
Yeah. Probably the largest group that I have worked with where we have had the methyl tetrahydrofolate reductase test, MTHFR test, is a group of kids that I work with that have a rare genetic disorder called Prader-Willi syndrome. And almost all of them have had that test, and almost all of them are homozygous, which puts them at risk for, for developing conditions that are associated with Prader-Willi syndrome, including obesity, diabetes, behavior, cognitive issues, and so on. So these children are all on supplements because this has been looked into. I wasn't the one that was involved in that, but I was involved in getting them all on a modified ketogenic diet to see if it would help one of the worst symptoms of this disorder, and that symptom is a voracious appetite. So they develop at about between age 1 and 3, they develop the inability to be satiated. They're just hungry, 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 hungry all the time, and that typically leads to obesity and all the other issues that go along with obesity. So what we did was we put these kids on a modified ketogenic diet to see if it would help with appetite control. And 9 of the 10 children that we did this to had significant improvement in appetite control. And we looked at actually 6 different factors, including behavior, energy level, their weight, and quality of life, and so forth. And many of them had, all of them had improvement in quality of life. That's probably the most significant point, but that 9 out of 10 of them had significant improvement in appetite, so much so that the parents were able to take them into social situations and not worry about them gorging themselves on the food that was available.
Wow. I'm going to have to cut you off because you got to get out the door to get some work done.
Okay.
But I would love to reserve the right to pick up and to go into some of these other issues. It's just fascinating to talk to you. So we'll communicate on that later. And thank you very, very, very much, Beth.
You're so welcome. It was a joy to chat with you.
Oh, absolutely it was. Now go do your work. Take care.
All right. Take care.
Bye-bye.
Bye, everyone.
I just want to follow up on the conversation I just had with Beth. She is so comprehensive and such a genuine person that you obviously got with that, and all these specific conditions that can be treated as with the same therapy, with modification of the same therapy, is just such an endorsement for the ketogenic diet, and that it's endless sort of revelations of yet another benefit. So I'll leave it at that, and I certainly hope to talk to her again and to pick her brains at some of these other issues. I didn't even get through 1/10 of the questions that I had for her. So with that, thank you for today's episode, listening to today's episode of the Keto Naturopath. And if you have any questions, send them in to Dr. Goldkamp at ketonaturopath.com. And we'll see you on the next episode.
Thanks for listening. For anybody who has any questions, feel free to contact me on our Facebook group, Keto Naturopath, same name as our podcast. I'm open to any questions, and we plod through the good and the bad, the difficult and the easy, week after week.